Hello, everybody. My name is Nikolay. Thank you for this opportunity to present a topic that probably will be slightly different from what you're used to listen. But I hope that this will be a more practical view, what we are using as tools and what are the possibilities for you to help us to make better healthcare and particularly better neurosurgery. So my topic will be emerging technologies and innovations in neurosurgery. I'm a neurosurgeon from University Hospital Pirogov, one of the big hospitals in Bulgaria. Thanks to the organizers for this invitation. So what is innovation? Merriam-Webster dictionary is quite brief and straightforward. This is a new idea, method, or device, a novelty. ChatGPT is giving a more complicated explanation of innovation. This is a process of creating, implementing new ideas, products, services, processes, and methods that result in a significant improvement or novel approach to addressing a problem, meeting a need, or achieving a specific goal. So as we can see, we can find innovations in very different places, in ideas, products, services. So we have to bear this in mind. When we are talking about treating patients, this is a quite complicated process. Usually start with the patient experience, the first signs of health problem that he's reporting for. Then he engages, and we start a whole cycle of gathering of information. Of course, there are physical examination, diagnostic tools that we are using, different type of diagnosing tools, consultations, etc. Finally, we have to achieve to have some kind of diagnosis and general plan of treatment, and to start with this treatment. Usually, there are two directions. In one case, we have an outcome, so we have resolved the problems in one way or another, or we have to come back to this complicated process of diagnosis and thinking what to do with this patient. So we may have innovation in every single part of this complicated scheme, of this complicated process. So the opportunities to innovate in medicine are really huge. I would like to attract your attention to the innovations. This is a report made by Dr. Meshko. He's presenting himself as medical futurist, so he's discussing not only things that are happening nowadays, but things that probably will happen in the near future. So he identified 50 emerging digital health trends. You can find them here, and of course you can dig in the internet for more information. But more of them are biotechnology, digital health research, etc. So it's very interesting. I will talk about these 7 or 8 innovations. These are 3D printings, robotic-assisted surgery, augmented virtual reality, advanced intraoperative imaging, focused ultrasound and laser interstitial thermotherapy, artificial intelligence and machine learning in medicine and in neurosurgery, brain-computer interface, and neurorestoration. And I will try to make a very short analysis for every one of these technologies, in which part of the Gardner hype cycle they are. As you know, every new product is going on the market following this Gardner hype cycle. We have a technology trigger, then we have a peak of inflated expectations. Of course, there is we pass through a disillusionment, and finally we have a plateau of productivity. I will start with 3D printing. 3D printing is also called additive manufacturing. It is not really new. The first 3D printing machines have been built in the 80s, I think, or even in the late 70s, but they have been very, very expensive, and only the most advanced laboratories could have this type of machines. Basically, the idea is that we are creating new objects layer by layer, and under computer control, we are following a pre-programmed 3D model. There are several things that have helped to this technology to spread broadly. This is the computer-assisted design, the development of computer-assisted manufacturing. Of course, the different type of additive manufacturing technologies that have been developed during the time. These are SLA, FDM, SLM, and of course the new materials that are building these objects layer by layer. So in neurosurgery, we are using 3D printing mainly in two main directions. From one side, this is the preoperative planning. From the other side, this is then the manufacturing of individualized, personalized implants. Regarding the preoperative planning, there are two main directions that we can use. From one side, this is good for the patients to explain them what will happen during the surgery, so it's a patient education tool. On the other hand, this is a preparation for the surgeon for the surgery, because you can make a simulation of the surgery before going in the operating theater. So it's very important for us to prepare ourselves without taking risk to make any kind of injury of the patient. Regarding the individual implants, I will give you some examples with cranial defects in craniomaxillofacial surgery, and of course in spinal surgery with spinal implants. Here are some images. This is a cranial defect. Usually we have this type. This is after a brain injury. There is an injury also of the bony structures. So frequently when we have to reconstruct them, the defect is with very complicated shape, and it's not easy to reconstruct it. So we need to make it 3D printed. This part should be 3D printed. We are using different type of materials. We can use titanium, but nowadays we are using more PEEK. This is polyethyl ether ketone, a special polymer that is light and very suitable for biological use in surgical use. Regarding craniomaxillofacial surgery, this is 3D printing is a very strong tool to prepare surgery. As you can see, this is the inferior part of the mandible, and sometimes we need to make resection of this bone. Usually this is during oncology surgery, and we have to replace this part of the bone. And we can prepare everything by taking bone from another part of the body, but we may have this type of tools to know exactly where to cut in such a manner that these parts will have exactly this shape. Additionally, we have this plate that is preformed. So basically, thanks to this tool, we can reduce the operative time with a lot of hours, because if we don't have these tools, we have to measure on every single step. Usually we are not so precise. So this is a very good tool to reduce the number of complications and to reduce the operative time. And these are different 3D printed implants, mainly from titanium, that we use in spine surgery in different parts to replace different parts of the spine. So if we have to assess the 3D printing following the Gartner hype cycle, we have to say that we are over the peak of inflated expectations. This has been probably 10 years ago, the peak of the inflated expectations, when we thought that probably we will have everything individualized. We will print all the implants in our hospitals. Of course, the business is not going like this, so the big companies have been flexible enough to propose products that make the 3D printing not so important. So now 3D printing have a specific part that is, in the cases, some of them I just presented, and I think that this is the reason why we are somewhere here. What's for the future? Regarding 3D printing, there is a very interesting part, and this is the bioprinting. The bioprinting is printing with cells. Basically, the idea is that we have different layer of cells. We start to have different, the cells starting to have different capabilities, different different capabilities than the single layer of one type of cell. So there is a lot of hope that with this type of 3D bioprinting, we will be able to make a lot of experiments, especially in pharmacology, imitating organs, internal organs of the body. Neural navigation, this is the first step. I will talk about this because it's the first step before robotization. And this is an important part about, to enable and to make robotization possible. What is the problem that we have as neurosurgeons? The problem is that the brain is an amorph structure. So when you are working in the brain, you cannot be sure where exactly you are. You don't have anatomical repairs there. This is why at the end of last century, this concept for neural navigation started to emerge. Basically, the idea is that we make some kind of image study, usually it's CT or MRI. Following this image study, we make a 3D model, and then we put the patient on the operating theater. We have our 3D model, and we calibrate the position of the patient regarding the 3D model, or vice versa, the 3D model following the position of the patient. In these manners, we have special tools, and when we point with these tools, with these pointers, we can see this pointer on our 3D model. So this permits us to see exactly where we are in the brain without seeing any structure. This is very important for us, for the precision, for the planning of the craniotomies, for some very precise and guided biopsies, etc. So this is a very important tool. It has been really developed for in a user-friendly manner in the beginning of this century, and nowadays it's part of our everyday work. It's quite expensive as a tool, but this logic was important because this is how it looks in the operating theater. This is the endoscope in this case, and here we see the image, the 3D image. And when we point with the pointer, we see exactly our trajectory and what direction we should take to go directly to the tumor, to avoid other structures as vessels, etc. So this is a very useful tool, and it was the basis for the robotic-assisted surgery. The notion of robot has been for the first time used in 1921 from Karl Čapek, and robot was the name for a humanoid who is doing things that are repetitive or necessitating a lot of power that we as humans don't have. In neurosurgery, the first attempt to use robots was in 1985. It was a Puma CT-guided brain biopsy robot, which was not extremely successful. In 1997, the Da Vinci system has become available on the markets. Nowadays, the Da Vinci system is almost mandatory for most type of surgeries, especially visceral surgeries. Obstetric gynecology, urology, thoracic surgery, but not in neurosurgery. The reason is that there is some specificity that making our specialty quite different from the other visceral surgeries. But we started to have our robots, especially in spine surgery, in the beginning of this century. So usually there are two types of robot, master-slave, as the Da Vinci. So you are moving your hands, and the robot is moving his members, or how to take the instruments. And the other are the robotic guidance platform. This is what we are using in spinal surgery. So in this case, the robots, we are planning some trajectories because we have to put screws and in specific anatomical part of the body, of the spine. So the robot is guiding us to be very precise following these trajectories. Nowadays, we had the chance to work with two generations of the Circ robotic arm. This was the first one. It was in 2019. We started to use it since the very beginning and the introduction of the system. Now we have the second generation, which is, of course, more sophisticated and with more capabilities. So basically, the robot, this is part of the spine. We have to put our screws And if we don't put them following the precise trajectory, we can injure neurostructures, the spinal cord, or eventually some vessels. And we have a very narrow field, so the trajectory should be extremely precise. And the robot is suggesting us, following the image study, is suggesting us where and how to put the screws. And then the video doesn't work anyway. We follow with our instruments these trajectories to put the screws in exactly this position. So I would say that this is something extremely useful. Putting screws like this it took me probably 10 years with a lot of courses, a lot of educational events, a lot of cadaver courses, a lot of X-ray exposure. Nowadays, it's more like a game. Our young neurosurgeons are putting the information in the computer. The computer is suggesting the trajectory, and if you confirm that this is the correct trajectory, the robot is following the positioning in such a manner that you can put your screws exactly in this position. So it's a huge, I would say, democratization in the knowledge. So you can imagine some 15, 20 years ago, you needed 5, 10 years to put screws like this. Now a young neurosurgeon can do it with a quite good precision. So this is a huge advancement in security and of course in possibility for the young neurosurgeons to make complicated operations. This is another tool that is related to navigation and to robots. This is some kind, I would say, robotized intraoperative CT scan. As I mentioned, we are using pre-operative images to make 3D model that we're going to use in the operating theater for navigation. The problem with navigation is that usually we have these images a few days before the surgery. Thanks to this tool, we can have the images in the surgery, in the operating theater, immediately before and, if necessary, during the operation. Of course, this gives you a lot of additional precision because we are acquiring the information in the very same moment that we are operating. So this is the most accurate and actual information. Yes, this is an X-ray based system, so it's a CT scan, more as a CT scan, so you don't have problems with metals. I'm going to talk about intraoperative MRIs a little bit later, but when you have MRI, you have this problem because the magnetic field should be quite strong, so you cannot use all type of instruments. So this is a very new as a tool, and fortunately we have a chance to work with it, and I can confirm that the level of precision is really impressive. So if we have to talk about robotic-assisted surgery, I think that things are growing very fast now. We know this type of systems for more than 20 years, but now, thanks to the development of technologies, things are growing very rapidly. We have a lot of new possibilities with every new version and every new system. So we have nowadays automatic vertebral labeling, automatic measurement of all the parameters of the spine, automatic screw planning, automatic drilling capabilities. It's very impressive what's happening just for a few years time. So I'm really optimistic that these instruments that have completely changed the field of spinal surgery for 10 years will continue to develop very fast and will give us completely new possibilities in the very few years to come. Augmented reality and virtual reality, there are two important points here. One of them is education, and the other one is the possibility to use it during surgery. This is also as navigation, but you can visualize different structures of the brain following the position of your patient. You can visualize them, of course, without seeing them. So this is the augmented reality, and this can give you possibility to make planning of your craniotomy, of your trajectories. So it's something like navigation, but it's just in front of your eyes. So you can inject a lot of information and see a lot of things that usually you cannot see without this type of tools. And of course, we have this type of tools are completely reshaping education. We know that nowadays we have to usually a physician you need to study for 6 years. Then if you want to become a specialist, you need 5 more years, so it's 11. And I would say that this is just the beginning of your real development of specialists. So this is a very, very long period of time. Thanks to tools like this, we can push a little bit and to shorten the period of education, the period of development of specialists, especially in specific fields. So I'm not sure where exactly we are. We had a lot of expectations that things will completely change. Now I think that we are in this part of the cycle, but still I think that these tools, augmented and virtual reality, will become better and better and to be used more and more on everyday basis in medicine and especially in neurosurgery. Intraoperative imaging, this is a complicated topic because it's very specific, but as I mentioned, the brain is quite amorphous as a structure, so it's not really to orient yourself inside this amorphous mass. Very frequently, the lesions that we are looking for, tumors or vascular regions, are not really visible or easy visible. That's why we need additional tools for having better visualization, and these are fluorescence guide surgery. We are using nowadays Raman spectroscopy, which is a possibility to see, to have an information about the histological characteristics of the tissue that you see. Usually you see the same tissue, you cannot make a differentiation between the tumor or the part of the brain that is infiltrated by the tumor and the brain itself. Thanks to this type of tools, you can have better visualization. Where is the tumor? Where are the burdens of the tumor? And of course, to be more invasive and to remove more oncological tissues. Another tool, this is the intraoperative MRI that was mentioned. Unfortunately, this is still extremely expensive. It can be used only in a limited number. It's useful only in a limited number of pathologies, and you need to change completely your operating theater because you cannot use metals, especially in the field, in the part that will be scanned by the MRI. That's why, especially for this technique, I think that we are more in this part, or probably here in the plateau of productivity. But especially regarding this type of spectroscopy and different type of analysis, intraoperative real-time analysis of the histological type of tissue, we are just in the beginning, and we have a lot of hope that this will be a strong additional tool for us to make more radical surgeries. Some things that are just coming, especially in neurosurgery, that they have been used in different fields of oncology, mainly in different parts of the bodies, but the brain is protected by the cranium, so this is limiting a little bit this function. This is the focused ultrasound, so we have waves that concentrate and rise the temperature in a very small and focused part of the brain, or the laser interstitial thermotherapy, when we use some laser probes that we, thanks to navigation, we put exactly in the location that we need. This can be a small metastasis, a small tumor, or other type of structures or lesions. And we are doing MRI follow-up of the rising of the temperature, and we are destroying this part of the brain or of the tumor, with ablation, with thermal energy. This is we are still looking for the exact indications for application of this type of tools. So this is something that is really emerging. We had a lot of hope because this is minimally invasive or even non-invasive. So I think that we are just in the beginning. Yes? This can be very precise. So basically, the idea is that you have a concrete shape that is really up to millimeter. You know up to millimeter what you are destroying. So it's quite more or less, yes, I would say. So we have to be very precise because structures in the brain, as you know, are very concentrated, especially in certain regions. So yes, such type of precision is necessary.
While inserting the laser probe, how much damage do you do on the way?
You don't do a lot of damage because usually the brain permits you to, of course, you have to calculate the trajectory, where exactly to go through, because there are some regions that are very, as I mentioned, with a lot of functions that are concentrated, so you cannot go through that. You go through other parts of the brain that are less involved in the active functioning of the brain. The frontal lobe. The frontal lobe, sometimes the basal part of the temporal lobe, there are less functions there. So you can easily go, especially with a tool like this. This is really very, how to say it, non-invasive, non-destructive. Where? Yes, that's true, but let's say that it's very tolerant. There are some options for plasticity, I would say, and the frontal lobe, generally speaking, is very tolerant to different type of injuries. So there is options for substitutions of these functions, even when you have a destruction of the whole lobe during trauma or something like this. So it's, yeah, the frontal lobe definitely have a lot of importance for the cognitive and higher cognitive functions and for the emotions, but still we can substitute these functions quite well, which is not true, let's say, for the visual cortex, which is here in the occipital lobe, or the motor cortex, which is here, where every single destruction of a small part of the cortex will lead to some kind of dysfunction and weakness of some certain muscles in our body. So something that is, you are definitely more in this topic than me, but something that we are talking a lot about for the last years, the artificial intelligence. I think that things have started really when we talk about machines that are stronger than us from intellectual point of view. In 1997 with Deep Blue, this was a historical moment when one of the field when we felt very strong has been overcome by this machine and by brute force, because this have been a machine. This was a machine capable to do a lot of calculations for a very short period of time. Regarding that, we have a limited number of possible movement and limited number of positions. If you have enough calculating power, you can calculate every single move and, of course, choose the best one. So this type of brute force was the first step. But then we thought that the game of Go will be probably the last castle that will protect us as intellectual power, because this is a Chinese game of more than 300 years, and the number of combinations here is not simply huge and enormous, but I think that it's not in the near future we will not be able to calculate all the possible movements. So you cannot use brute force to shape your Go game. But in 2016, this happened thanks to AlphaGo. This was an algorithm, as I mentioned, probably you know even better, but that was especially dedicated to play in this game. And the Korean champion lost, I think, 2 or 3 consecutive games. So this was the next step in the development of this intellectual power of the machines. Nowadays, of course, everyone is talking about the large language models, and they are becoming better and better. So we have ChatGPT equals doctors in diagnostic and emergency departments, or even outperforming physicians. So these things are happening now. How long you people and society will need physicians, I don't know. I still think that we have a few decades, but still things are growing up and up. And here we can see, because how to measure the interest in certain topic, of course, following the investments that are made in this domain. In the AI, we have different fields, a lot of different fields of AI, but as we can see, the large language models and the image models are really attracting most of the investments for the last years. So when we have investments, of course, we may expect also to have good results. And we can see these results. This is an AI index technical performance benchmarking versus humans. So we can see the different type of AI that have been used for image classification. We see that in 2015, the technical performance of AI has become better than the human baseline. We have different fields as English language also overcome. We have a multitasking language. It started in 2019, but nowadays machines are better than us. Visual reasoning, almost in every single field, we have been surpassed for the last 2, 3, 4 years. So this is happening now. Especially in neurosurgery, AI can be used for medical imaging analysis, for early diagnosis and triage, for decision support systems. In spinal surgery, as it was demonstrated, mainly navigation, and to support us and help us for administrative work. We are just in the beginning of the development of these tools. Of course, we cannot be sure what will happen, but I would say that the quantity and the quality of everything that is happening and the speed are quite frightening. A few words about brain-computer interface. This is also not a new topic, but only recently we had, I would say, substantial advancements. Walking naturally after spinal cord injury using a brain-spine interface. This would be a title from some kind of futurist and science fiction journal or whatever. But this, in fact, is a publication in Nature from 2024. Indeed, a team from Switzerland made possible with implants that are even not inside the brain. They are outside the brain. We had some kind of envelope that is protecting our brains, and the name is Duramatter. So this is a very important protective envelope, and they are outside this envelope. This is very important because when you open this envelope, you risk to have more infections. There are reactions of the brain tissue to this invasion, and in this case, we are even outside this envelope, which was not possible with the sensors that we had just until a few years. With our sensors that we have now, you can capture the signals from the motor cortex that I mentioned. You can use very complicated algorithms and AI to extract these very, very, very miniature, very weak signals. You can bypass the zone of the spinal cord injury, and you can go down to the spinal cord and spinal nerves below the injury, and you can stimulate them in a special manner, in a manner that is making the muscles contract and imitating a natural walk. So this is very complicated because you have to, there is consecutive muscles that should be activated and then relaxated. All the algorithms have been found thanks to AI and neural networks, etc. But finally, what we have as a result is that we had a naturally, I would say, walking. This is not exactly walking, but it is an independent displacement with your own body without additional tools after spinal cord injury, which is absolutely not possible just a few years ago. Yeah?
And how in that situation with that, like we receive like a data from like let's say about flex or reflex or something like that when we are walking.
Yeah.
So how our brain will know that we are doing not now a reflex, not a special walk.
This system should be educated, and this is a quite complicated and time-consuming process. So you educate yourself to think about certain movements, and when you think about them, the system is translating this as certain type of movement. So it's not something that you can buy in the shop here in the neighborhood and put in the brain of a paralyzed patient. It's still in the phase of development, but already we have several patients that have proved that this is possible. Once it's possible, we're gonna fine-tuning it, we're gonna develop it, but it is possible. So, yeah.
Did you have any idea about the power consumption of the cortical?
No, really, no idea.
Can I ask from the Zoom about epilepsy operations? Do you do it here?
Very low as milliwatts, microwatts. Okay,
We are at all stay there.
right.
But it works quite well.
So if I understood correctly, one has to remove the skull, right? For this?
Yeah, this is a small burr hole in the skull.
Like, it's really not a high.
No, it's low. In fact, this is a huge advancement. Yeah, the previous versions of these electrodes has to be implanted in the brain like small pins. One of the major problems, of course, is infection. But the other problem is that the brain is reacting against these foreign tissues and are making some kind of protective layer. So they stop working, in fact, in a several months' time. So being able to acquire information without implanting in the brain is a huge step ahead.
The tissue you said, the skull protective tissue, of course, you also suffer from the neural recording, chronic implant.
Yeah, exactly. And by the way, this is also, you know, that Neuralink has been bought by Elon Musk 2 years ago. The fact that investor as Elon Musk is orientating his investment in this direction is very important because he's a leader and a lot of people will follow him. And as I mentioned, if there are enough money, probably we will have advancement in this field. Most probably we will have. And they are trying to develop this type of sensors and implant them with a robot because, of course, you can use these signals for trying to make walk people with spinal cord injury, but you can use them for everything, as a TV command, as a remote control, as everything. I mean, if you educate the system to extract the correct signals from your motor cortex, you can use them to control your mouse, your keyboard, whatever. So I think that there is a lot of future, a lot of future development. Of course, it's a technology that is still growing and still developing, but I think that some very important technical burdens have been overcome, and I hope that we're going to have good news there. Of course, this is something from June 1st, 2026, that China has approved the world's first invasive brain-computer chip. This is an invasive one, but things are growing in this field. So I think that we are here. We are here in the very beginning. And very important topic, neurorestoration. Unfortunately, neural tissue, we don't have control for any kind of restoration. We know that our bone have a good restoration possibilities. We know that our skin have good restoration quality, but not the neural structures. Unfortunately, neural structures can be injured by a lot of agents, by trauma, by stroke, by different type of agents. So we need to work on this neural restoration. There are a lot a lot of directions that different scientific teams are working with stem cells, with embryonic stem cells, etc. These are very, very complicated things. The truth is that we are investing in neuro regeneration, in neuro restoration for now, I think more than 40, 60 years, very intensively, and the result is close to zero. So it is as it is. From this point of view, I don't know where we are, but thanks to the new technologies that we have, hopefully we will find new directions to develop, and probably someday one of these directions of development of the neural restoration will work well enough for us to have this too. This is one of the options, neuroplasticity, but it's a very slow process and a very difficult to control process. Here again, if we can stimulate neuroplasticity, this will be a great tool for us to use. So, if I have to reiterate, these are the technologies that I discussed with 3D printing, robotic assisted surgeries, etc., that are reshaping the field of neurosurgery, and they are helping us on different parts in this complicated process of trying to treat our patients. But in conclusion, we can say that innovation is equal to progress. Innovation is a perpetual process. Innovations can be everywhere, in every single step of this complicated process. And the best innovation is to be and remain innovative, remain open-minded, and to remain in communication, because all future decisions will be interdisciplinary. So the best is yet to come. Thank you for your attention.
The question by Natasha on Zoom. Can we hear her?
Do you hear me?
Yes.
Yes, we hear you.
I just wondered about epilepsy operation. Are you doing it?
There is a different type of epilepsy operations that can be performed. We are performing some of them. Yes, what is the question?
No, just that I was working on localizing the epileptic focus. So I just wonder, maybe the new technology that you have with laser are less, are together with the localization gives better results. But
exactly, this
anyhow,
is one
just
of the field of
curious.
application of this type, because this is ablation. So we can destruct, this is a thermal destruction of part of the brain of the tumor or whatever. In the case of epilepsy, if we can localize a small volume with pathological signal that is inducing the epilepsy, we can destroy it with this type of technique, and definitely this is one of the field of application.
Thank you. And another question, what you showed about brain-machine interface that activate the foot, the leg of someone who's paralyzed. So you connect it to the premotor cortex probably, and the thoughts are activating. Do you have anything about cognitive or sensation that you have something like that you do?
No, I wouldn't say. There are a lot in the modern psychology and psychiatry and behavioral sciences. There are a lot of studies with the so-called fMRI, functional MRI. There is some advancements in this field, but I'm not really sure that the fMRI is a very sensitive technique, very time-consuming and expensive technique, and we are not absolutely sure that all the results that this technique produces are completely correct, and we can make a direct relation between certain zones of the brain and their activation with some emotions or some thoughts, etc. but still we are working a lot. There are very powerful MRIs that are installed in the world, in Europe, up to 8 Tesla, which is extremely powerful. Usually we are using 1.5 up to 3 Tesla, and this is completely sufficient for us as physicians. But for the needs of cognitive psychology, etc., they are using more powerful tools. There is a lot of investigation, but I'm still not, I cannot really reply to your question.
Thank you. Lovely talk.
Thank you.
Didn't talk about it, but I heard the term gamma knife. Can you tell something about that?
Gamma knife is exactly like this. This is a concept that was born in the 70s. And basically, this is a tool for radiation therapy. And there are very small and very precise beams of radiation, different type of radiation. And they are crossing in a single point that can be delimited with a high precision. I think that it's under 1 millimeter with different shape. So you cross a lot of it's not X-ray, but a lot of radiation rays in a certain volume that you, thanks to the software, you can present to what part of the brain or what part of the tumor you want to have the highest irradiation, and the computer calculate it and make in such a manner that certain beams cross exactly in this point, in this shape, and in this manner you have a very low dose in your brain, but a very high dose in the point of crossing these beams. So this is the concept of gamma knife. You can do it with different tools, with CyberKnife, with Linac, etc. But this is the concept: a high concentration in one small part and low concentration in the rest of the brain. Yes.
Thank you for this question. I heard like when Neuralink announced at 2019. The check that let's say that someone lost her ability to see, and there's like a cut or a problem in that she hasn't got. So if they put in like 2 chips, let's say, so maybe the person will like see again. So I don't know if that's applicable or is that acceptable. Like, can do it or not?
Restoration of the vision is one of the main directions of development of this type of tools. Unfortunately, we still don't have good results. Last year in the United States, in Boston, I think, they described a chip that is stimulating part of the cortex and is restoring some kind of rudimentary vision. This means that you are really seeing only shapes, but very, very, very basically. But still, for someone who has lost his vision, this can be extremely important in the everyday life. But still, unfortunately, these tools are not well developed enough. And vision looks like something very simple, but in fact, it is not. No, I mean, it is simple from this point of view that we know every single molecular layer, where everything is passing through, what are the chemicals that are transmitting. We know everything, but still we cannot, by stimulating the cortex, it's difficult even to produce a straight line. So this is a huge challenge.
If I may add to this, Europe is a core companies and there is Peter Rossum in Amsterdam.
Yeah, Amsterdam is one of the well-known laboratories.
Peter Rossum.
And they are in, we have this in Spain, edge.
Yeah.
There is crazy stuff happening. So like one patient, they stimulated the patient, and then after some time the patient could see again, like without the stimulation. They just stimulated the brain to restore the vision. In this one patient, they only have a handful of people restoring.
Very last.
Yes, in the care labs, the cover there. they have just recently, I think in April, they came up with a method for eye restoration tested on rats. So he's saying that it's about to come out next year. You can check that out. Harvard Medical School, the David Sinclair Labs.
Hopefully, yeah.
Okay, now I want
Thank
to
you very
thank
much.